Hello, and welcome to the IB Digest podcast from Takeda. I'm Will Mountford, and this is our second part of an interview with Dr. Ahmed Sultan about the use of histologic remission for ulcerative colitis.
If a patient were to come to you or to one of your colleagues and say, I've done some reading, I've heard about histologic remission, I want that. I think that's what is going to, in my mind, in my body, feel like I am cured, I am safe, my life is better if I get histologic remission. How do I get there? What would your response be to them?
First of all, the key to success of treatment is an early diagnosis. So if you have the symptoms early, you need to be properly investigated and don't neglect your symptoms. Second, once you have an early diagnosis, you need to initiate the proper early treatment as well. The proper early treatment should actually, once you have an early diagnosis, you need to start the proper treatment for your case. And this is by assessing your disease severity. Like we said before, if you are young in age, have extensive disease, your CRP is high, you require systemic steroid at the start of the treatment, you are likely to need a higher and more advanced medication than the conventional therapy. And here comes the role of the biological agents or even the newer small molecules or the JAK inhibitors. Once you have an early diagnosis and you initiate the proper therapy, the third part is to have a good adherence to your medications. You need not to skip any dosage. You need to do the proper follow-up with your physicians. You need to repeat your lab test on a regular basis, assess your symptoms clinically on a regular basis, and you also need to repeat the colonoscopy on the proper time as advised by your physicians according to your case. And ulcerative colitis you usually repeat within 6 months to assess the medication's efficiency.
Hello, everyone. It's really a great pleasure to have you again at our second IBD Grand Rounds of the year and our second with IBD Leuven, which is one of the premier, of course, IBD centers in the world. We have the great pleasure of having João Sabino, an assistant professor at KU Leuven, with us today. We were also supposed to have Mark Ferranti, but unfortunately something came up and he couldn't join us tonight. So we're really looking forward to a great session. I would like to thank the presenters for accepting to present, Dr. Zahir Kutubi from Cleveland Clinic, Abu Dhabi, United Arab Emirates, and Dr. Osama Salim Abada from Alexandria University from Cairo. So thanks to the speakers. I also would like to thank the attendees, all of them, for joining us tonight. I'd like to thank Takeda for sponsoring this event, and we're looking forward to a great session. So I'll pass it on to João to kick off this event.
Thank you very much for this very kind introduction. And I must excuse my colleague. He told me to send these excuses for not being able to be here today. So we have two very interesting cases today to discuss. And I would like to invite the audience, if you have any questions, please put it in the chat, and we will address it if they are not addressed already by myself or by the other experts joining online. So without further ado, I would like to introduce Professor Osama Ebada Salem from Alexandria, Egypt, and he will present the first case. So the floor is yours.
Hello, everybody. Thank you for Professor Ala for inviting me to share with you this prestigious event. And thank you for Leuven, of course, for having us with them. And I will try to present my case. This is an ulcerative colitis patient who came who has a 47 years old female patient diagnosed with ulcerative colitis for 8 years prior to the overall stable clinical course. Strikingly, the patient presented with bilateral upper and lower limb gangrenous patches at the fingers and toes, as seen in these pictures, as well as she had oral aphthoid ulcers, multiple erythema nodosum, pyoderma gangrenosum, both lower limbs and upper limbs at the back, and reported this happened to occur over the past 5 days.
Dr. Salem, may I ask something?
Yes.
This happens very suddenly, if I understand.
Yes.
So in 5 days,
5 days.
and there was still evolving. But if I understand correctly, the ulcerative colitis was at this moment she had no symptoms.
Yeah. She had just 4
Okay,
bowel
yeah.
movements with occasional blood and no other symptoms for GI. And we did labs for her, and hemoglobin was 13.8, CRP was very high, 63, and calprotectin was 580. In addition to the nodosum and pyoderma gangrenosum and erythema nodosum, as well as the gangrene, we had also joint effusion over wrists and knees. Also did a Doppler study, and for both upper and lower limbs, and both were normal. We started immediately IV steroids for 3 days, but we didn't have improvement of the impending gangrene status, as well as other extra-intestinal manifestations. So we decided to try to introduce the infliximab. Why infliximab? Because we have 2 studies assess the effectiveness of imaging allostasis coagulation. One of them was a retrospective study on 53 patients with Crohn's disease, and they found significantly reduced hypercoagulation markers, including platelet count, mean platelet volume, ESR and CRP, as well as the fibrinogen and D-dimer levels were decreased after infliximab treatment. Also, another study in 2015 was prospective, and they found the responders having a significant reduction in coagulation parameters, as well as they find suggests that infliximab may have a beneficial effect on the vascular extraintestinal manifestations by improving coagulation and reducing hypercoagulable markers. So we started infliximab. The patient was put on standard dose of 5 milligram per kg, and after 1 week of therapy, we noticed improvement of the oral ulcers, as well as we started to have oropharyngeal candidiasis, for which the patient diflucan was prescribed, but we didn't have a sort of adequate response to the impending gangrene status in this case. So, and the diarrhea did not improve, but to the opposite, it worsened to 4 to 5 bowel movement per day with few blood spots in the stools. No evident bleeding per rectum was noticed. Hemoglobin dropped to 8.6, as well as CRP didn't improve much, but still 34. And the patient, the corticosteroid was tried to trap it because we started infliximab, and we put IV iron was prescribed for the diminished hemoglobin level.
And sorry, Dr. Salem, do you
Yes.
performed any endoscopy at this point?
Yes, the next week, after a week, after the acceleration of the dose of infliximab, for this reason, we accelerated the dose of infliximab to be on the next dose on this week, and another 3rd dose of the 3rd week. And we find after the second dose, significant improvement of arthritis and dermatological manifestations, and disappearance of the oral ulcers and candidiasis were noted. Also, some improvement of the ischemic fingers and toes were noted in these patients. After the third dose, we did the colonoscopy, and we find E1, MES2, and biopsies were active, you see, with no dysplasia, still having anemia, 8.9, and calprotectin was still high, but CRP was improving. So we continue IV iron, and the corticosteroids were stopped. And a month later, first maintenance of infliximab dose, we noticed improvement of the bowel movement to be 2 bowel movement per day, and improvement of the fingers and toes, improvement of the anemia to be 12 now, CRP negative, calprotectin still 455. A month later, the second maintenance dose, we continue infliximab to be every month, not every 2 months, just to make sure that everything is better. And we have noticed a much improvement of the fingers and toes, and improvement of the anemia now disappeared, CRP negative, and calprotectin was negative.
And
Osama,
the doses, sorry, maybe we'll take.
We can just hold a bit and
Yeah,
just have a little
just
bit
to have an idea.
discussion. Yeah.
Indeed,
Yes.
because I was wondering a couple of
Yes.
questions about the approach. So,
Yes.
what was the dose of infliximab that you were giving at this
We
moment?
gave her 5 milligram kg per body weight, the standard dose, but we give it in an accelerated dose. So we give it 1 week, every
And
1
then-
week for 3 weeks. Then
Okay,
after
so
the
you-
3 weeks, we put it the first maintenance dose after 1 month and not 2 months. And the
And do you usually
third
work
dose
with
is-
higher doses?
Yes.
Okay.
Yeah, because we have a sort of problem with the insurance that
Okay.
that you can give 5 milligram every month. Yes, they can accept, but they cannot accept that you can give 10 milligram per kilogram body weight as a initial dose.
Okay,
So-
so you could not start. Sorry, Ala.
Yes, Osama, I just have a couple of questions. So
Yes.
the first question is, did you give anticoagulation at the same time?
Yes, yes.
Although the Dopplers were negative,
Oral
but certainly
anticoagulants
patient-
was prescribed, yes.
Yeah,
Yeah,
okay, that
for
makes sense.
the beginning, we started with IV,
Okay, IV heparin.
heparin.
Okay.
And then after that, we started the maintenance. We started to put oral anticoagulants, and was maintained the oral anticoagulant till there is the appearance of everything.
And pathophysiologically, your impression was this is a vasculitic type of reaction? Because it certainly
Yes.
doesn't seem to be an
Yes.
embolic phenomenon, because that would be pretty unusual to embolize to multiple fingers and toes.
Yes. Yes.
So it's
Yes.
more a
Yeah,
vasculitic type
Yes.
Yeah.
inflammatory reaction. Okay, got you. So
Yeah, I was.
complement levels, etc., things like that. With those, the rheumatology involved in the case?
At that time, no, because we did. We just found that this vascular event, we didn't have noticed that the arthritis was improved and was a sort of congruent with the activity. So we thought that we didn't need a sort of rheumatology advice at that moment.
But
And before, sorry, but last question. Before all of this happened, she never had scleroderma or any. I mean,
No.
she didn't have
She had
Raynaud
almost a
phenomenon or
stable-
anything before that, right?
Yeah, she was on just a standard dose of the treatment for the conventional treatment. So
Okay, gotcha. All right, thank you.
occasionally she had corticosteroid every 1 year or 2, but she didn't have a sort of biologic treatment before or has an extraintestinal manifestation before.
Gotcha.
Professor
Yeah,
Osama, do
yeah.
you mind just a very short question, because this is a very interesting case, but as Professor Ale has just mentioned, it's not
Yes.
unusual to be a case of gangrene or peripheral gangrene of the fingers in a case of inflammatory bowel or ulcerative colitis. So I would think that this could be a case, for example, of lupus or a rheumatological phenomena. So did you really do all an autoimmune profile in such a case just to exclude that we are dealing
She has been followed after that. Yes, I have seen it. This is what 3 years ago. This the presentation was 2021. But after that, till 2025 now, she has seen a rheumatologist to exclude any vasculitic event, and they said no, there is nothing there, no lupus and no rheumatoid arthritis.
Yeah, I wanted to say indeed that this seems like, when I saw the first images, that seems like a vasculitis. That's inflammation-driven vasculitis. We had a similar case, not with all the other extraintestinal, but it progressed very fast once the disease was still active. So it was a case of very active colitis. That's why I was very interested in knowing if you had any endoscopy before the infliximab.
Yes, we have had endoscopy, and it was ulcerative colitis E1, just MES2.
So it was just proctitis, because
only.
I think that's quite unusual that such a small active disease gives such a vascular, because this for me it's a inflammation-driven vasculitis. It seems so. So it's really interesting to see indeed. But it was proctitis, but it had a very huge impact, because it was a drop of hemoglobin of at least 5 points, if I'm not mistaken, which is indeed a quite severe disease activity.
Without evident bleeding. So we thought it could be another extraintestinal manifestation for the anemia. So after 3 months after infliximab, there was complete healing of these ischemic toes and fingers, and with some residual nail dystrophy that gradually healed completely over the next few months. And this is the pictures for 3 months duration. What is peculiar to this case is that the synchronous onset of the variety of extraintestinal manifestation that all happened at one time, the erythema nodosum, the pyoderma gangrenosum, the oral aphthoid ulcers, the peripheral arthritis for wrists and knees, and the vascular, which is the arterial now, impending gangrene, or as well as anemia and evident bleeding. So that this is a synchronous variety of extraintestinal manifestations, as opposed to the usual single or sometimes sequential extraintestinal manifestation. The second peculiar thing for this patient is the rare vascular extraintestinal manifestation with severe presentation with the impending gangrene that we don't usually see regularly. The third peculiar thing for this case is the need to have an accelerated approach of infliximab, because of this was mandatory to prevent the consequences of this impending gangrene. Also, the complete response to the anti-TNF therapy was achieved in this case.
And do you have any trough levels of infliximab? Just I was wondering, you had used an accelerated treatment scheme, so I was wondering if you have any drug levels to have an idea on the efficacy.
Yes, we had. It was at that time. It was okay. Of that escalation, it was okay. It wasn't very much high. It was around the 4 to 5, 6, I think. Worth lighting is the fact that TNF now, specifically infliximab, remains a most valuable effective drug, not only for acute severe colitis, but also, as in our case, in a morbid extraintestinal manifestation, especially with vascular insults. Higher doses of infliximab are beneficial and could be needed in desperate situations like our case.
Maybe I would like to pause.
This case was presented actually to the UEG week in 2021, and this is the presentation in this.
I would like to take a moment just to ask the faculty, because it's indeed the case where I would use a higher dose in a faster treatment scheme, just to have an idea on the faculty that it's here present today with us. If they've in their countries, if they have access to higher doses up front, would they give a higher dose or a faster scheme? I think we are today joined by Dr. Shev Mohair, George Costas, and also Turkey Alamehil. So please join in what would you do in this case?
I think Joao, maybe Turkey, hello Turkey, can maybe address the issue. He covered the recently, of course, published study on accelerated
Those.
dosing in acute severe ulcerative colitis. But this case really has so many peculiar things. Turkey, what is you may have come in a bit late, but would the predict study, or I mean not the predict study, the accelerated and 10 milligram versus 5 milligram per kilo dosing of infliximab, would that change your approach now, since we have kind of, if you want, good evidence that higher dose doesn't really do a difference?
Yeah, so I actually was there from the beginning. It's very interesting case Professor Osama presented. And clearly this was several years ago before the publication of a PREDICT UC earlier this year. However, I think what we're dealing with is, as mentioned before, is a form of vasculitis. It wasn't that the patient presented with acute severe ulcerative colitis. She did have diarrhea and rectal bleeding and high fecal calprotectin, but I think the main concern in her case was the changes in her skin. So probably if she presented now with purely acute severe UC, I wouldn't use higher doses or accelerated dosing based on the PREDICT UC. I agree with what was said earlier that we probably it would probably have been useful to get an input from a rheumatologist or a dermatologist to consider skin biopsy if needed. But it's a very interesting case.
So if I understand correctly, you would not use, based on the PREDICT UC, a higher dose or an intensified treatment scheme?
Yeah, that's correct.
Would you? Okay.
No, I wouldn't.
Okay. Yeah, we are still doing it. I think we still think that it's worthwhile. But I know that the PREDICT UC is there, that it showed no efficacy by day 7 and by day 14, and colectomy afterwards. There was some nuances then, though, but I still think that specifically in a faster case, because there are some studies showing that specifically if you use a patient predicted dose with the dashboard, as we call it, that it seems to work in some patients. So we do still do it in Leuven and as an intensified scheme, the 10 milligrams 0, 1, 4 in acute severe colitis. But I certainly agree that the data coming from the PREDICT UCs, it doesn't support this kind of strategy at this moment.
I think the fascinating thing here, as Osama mentioned, is that you have something that you can see and measure in front of you in terms of response. Now, normally clinically, we rely on bowel movements, etc. But here you have evident skin manifestations and finger manifestations and that's why I think, Osama, correct me if I'm wrong, I think the first dose you were underwhelmed with the response, and that's why you went into an accelerated type of regimen, right?
Yes. Yeah, sure.
Mm-hmm.
Yeah,
So
because
I
of course
think
we
we should
find that
customize the dosing, I think, depending on the case and the
I
presentation.
think indeed that's a message, because I think PREDICT UC is specifically for acute severe colitis. This is a little bit something else. We do it, I think, pyoderma gangrenosum, which is quite severe. We will use higher doses. And I think in a case where there is an increase of severity of the vasculitis, because in this case everything went well, some nail dystrophy, but I think the patient had the best outcome that she could have in this situation, because in our case, for example, the patient had the same vasculitis presentation on his feet, and he lost half of his feet with this kind of situation, and it led to colectomy. It was quite severe disease. So it's very interesting to see also that it was not just a vasculitis, but also an end situation. So and erythematosum and pyoderma and arthritis. It's very interesting.
Yeah, I mean there is this dichotomy, isn't it? It's like in most cases of the PG, metastatic PG, and these kind of presentations have, a punched out ulcers throughout the colon. They pretty have quite severe disease. Also, the oral ulcers that she got kind of tells you that it's something more systemic and somehow whatever triggered it, but I can't explain it really. It's a bit unusual.
It gave me the feeling that this was, for example, I know that this is UC, but this gave me the feeling that it's like Crohn's disease, right? You get the feeling when it's pyoderma, erythema, and everything else, it does give a feeling of something Crohn's-like, but indeed it was a colitis, a proctitis, so it's quite interesting.
But I think there's a point that I'd like to raise is that we really don't know what the effects of the anticoagulation that was given during this. So, and I don't know whether this was continued as an outpatient, but this is the curveball here, is that not only did we give anti-TNF alpha, but we gave so we also are saying that maybe there was some effect there too.
Yes, indeed. I think that we will never know, but indeed, I think if the patient was here, I would also give the treatment. So it's something that you don't know which one did the work. But I think in this case, this was inflammatory driven, and infliximab did most of the work probably.
I think the skin
another diagnosis to sorry, Ala, another diagnosis to entertain in this case is Behçet disease. The patient did have oral ulcers. She has manifestations of vasculitis, skin manifestations. So I think it's something to consider. We may be dealing with that entity rather than just pure ulcerative colitis. And to the point of using infliximab, absolutely, I agree. I think PREDICT UC was in patients with acute severe ulcerative colitis. And in this case, the clinicians looking after the patient had their back to the wall, basically. The patient was not responding to IV corticosteroids. There is no surgical option to treat the skin manifestation. So I think it was very reasonable to approach her.
I like the idea, Turkey. I mean, we see some Behçets here. Probably Joao doesn't see much Behçet in Belgium.
Less, indeed.
Yeah. So, I mean, generally speaking, the endoscopic image is different. They have ulcers and ileal disease is more predominant also as well. And clearly they don't have PG or EN as a manifestation, but it's a good thought. I think it's because this sounds vasculitic to me, and it's out of proportion to what was going on in the colon.
Yeah.
Yeah.
And this is, by the way, we are now going, I think, to some theory, but before we go there, we are now, if I understand correctly, 4 years further, because this was in 2021.
Yes.
How is she now? Is she still being treated with infliximab? Did she had any recurrence of the extraintestinal manifestations?
Yeah, I've seen her till now, which is I have seen it last month, and she didn't have extraintestinal manifestation, but with time, maybe around 2022, she started to have the loss of response to infliximab, and she has been put on ustekinumab, and she was on ustekinumab from 2023 till now. So, and we did multiple colonoscopy during that period, maybe in a year interval, and it was ulcerative colitis, nothing else improved. The last one was around the MES was 0 to 1. So we have a sort of control from this time till now on infliximab for 2 years, and then secukinumab for another 2 years.
Okay.
I think I have a few slides to show on the vascular.
Yes.
Yeah. Okay.
Yes.
All right.
Yeah, I will talk about the extraintestinal manifestations and try to show the vascular type. We have assorted the ECHO put this classification for extraintestinal manifestation, that we have classical extraintestinal manifestation, including uveitis, scleritis, episcleritis, and oral manifestation of thyroid ulcers, PSC, autoimmune hepatitis, spondyloarthropathy, whether axial or non-axial, and the skin pyoderma gangrenosum, erythema nodosum, and Sweet syndrome. And we put the association, which is the MS, stentorial lung, bronchiectasis, myocarditis, and complication. And for complications, they put the cardiovascular, ischemic heart disease, and vascular VE, anemia, fatigue, and maybe our patient having these, as well as the skin manifestation and the non-axial manifestation. Also, treatment, we have a sort of complication of treatment like pericarditis, pancreatitis, and osteoporosis. And the range over prevalence of extranasal manifestation range from 6% to 47%. But what is interesting is that the number of extranasal manifestation decreased, of course, with the numbers. With the exceeding numbers, you have less possibility of prevalence. So more patients will have one extranasal. However, 5 extranasal manifestation will be found in around less than 2% of the patients with extranasal manifestation. Also, the diagnosis of IBD, we have most of the IBD extranasal manifestation occurs after 75% after the incidence of IBD diagnosis, while few of them can predict for the IBD for 5 months, which is 25% of the time. The prevalence of extranasal manifestation vary according to them to different, whether the gastrointestinal we have PSC around 5%, while mucocutaneous could be up 5 to 10% in CD and 10% in ulcerative, pyoderma gangrenosum in the 0.4 to 2.6, more of course in ulcerative, oral ulcers 5 to 50%. Musculoskeletal, we have the arthritis, IBD arthritis, which is 10 to 20% in Crohn's and 5 to 15% in ulcerative colitis. Ocular manifestation, episcleritis, and uveitis. And the pulmonary pneumonitis is rare. And at last is the vascular. And the vascular, can you see the vascular disease? We don't know adequate prevalence, we know. Thromboembolism, 3 to 4-fold increase, and portal vein thrombosis is rare. The prevalence of extranasal manifestation in IBD was here. Of course, in Crohn's disease, more than ulcerative. Females usually have the erythema nodosum, pyoderma gangrenosum, and arthritis as our patient, and uveitis, episcleritis, while males more likely to develop ankylosing and VTE and primary sclerosing cholangitis. Location of Crohn's disease, L2 and L3, is associated with higher prevalence of extranasal manifestation, and also extranasal manifestation could be affected by geographic, ethnic factors, genetic, environmental, as well as the access to healthcare system. So several factors increase the likelihood of developing extranasal manifestations. Significantly, Crohn's more than ulcerative. Also, longer duration will have more frequent extranasal manifestation. CD patients more than ulcerative, I said. Female sex more than male. Age, disease activity, all have independent predictors for the presence of extranasal manifestation. Also, extensive ulcerative colitis significantly associated with the presence of extranasal manifestation, and not like our case as limited proctitis. Also, we need to see whether the extranasal manifestation is related to congruent or non-congruent with the activity of the IBD, because the axial arthropathy, of course, non-congruent, while the peripheral arthropathy to 2 types, one of them is congruent, and erythema nodosum congruent. Pyoderma gangrenosum could be congruent and non-congruent. Sweet syndrome, oral abscess, and episcleritis all are congruent. Uveitis non-congruent, and primary sclerosis could be and could not. So what about the vascular extranasal? Arterial is a result of systemic inflammation together with endothelial dysfunction. Aortic stiffness was reported to be an independent risk factor for Crohn's disease, and it increased in IBD patients. Also, IBD has increased risk of acute myocardial infarction and heart failure, as well as other cardiovascular insults. But till now, there is no specific preventive recommendations published, however, in agreement with the risk reduction for this in IBD patients. And this is a very recent meta-analysis that showed that the arterial vascular events increase about 1.2 more risk ratio in IBD patients for peripheral vascular disease, as well as other ischemic manifestation, 1.2 to 1.1 more than the usual. So inflammatory bowel disease increase the risk of arterial events. What about the venous events? IBD increased risk of VTEs, includes the splanchnic DVTs, as well as pulmonary embolism, and as we said, increased fold in 3%, and the prevalence around between 1.2 to 6.7, up to even 39% in post-mortem studies. This is published in the last publication of Jordan et al. This is the ECHO publication for extensor manifestation, and they put IBD as a minor to moderate risk factor for vascular events. Of course, vascular events also are characterized by high recurrence and poor prognosis, and the mortality rate increased for patients with non-VTE events, 2.5 times more in patients with vascular events than patients without VTE. Also, even it can reach up to 22%. This has led, of course, to the recent discussion with respect to medication that also increase the risk of VTE, such as JAK inhibitors. Pathophysiology behind the increased risk of VTE in patients with IBD is not yet clear. However, endothelial dysfunction, platelet activation, impaired fibrinolysis are contributing factors. Risk of VTE increases with the severity of inflammation and is highest in hospitalized patients as well as patients with acute severe ulcerative colitis. What about medications? Yes, patients on corticosteroids have more common. This is in a systemic review and meta-analysis just published a couple of years ago, that more common in patients having corticosteroids and less common in patients with TNF patients. And in this systemic review and meta-analysis, they showed that around 91,000 patients with IBD treated with TNF or conventional, and they found that patients already on TNF, they have less proportion to have significantly less likely to have VTE events than patients on corticosteroids and other conventional events. And they found in conclusion that biologics should be preferred over corticosteroids in cases of severe flare-ups and multiple VTE risk factors. Our take-away message that available literature indicates that corticosteroids may increase the risk of VTE, whereas anti-TNF agents may reduce the odds of these events compared to corticosteroids. And this emphasizes that patients with active disease flare-ups with high VTE risk, anti-TNF therapy should be our preferred over corticosteroid treatment. And thank you very much.
Thank you very much. It was a really nice overview of the extraintestinal manifestations in IBD, and also from the complication side, from the VTE and cardiovascular risk. I think that's something that we are giving more and more attention to it, is to see what's the risk, the baseline risk of the patient, taking into account the presence or absence of inflammation. Indeed, there's a lot of data now showing that the anti-TNF is better than to decrease the inflammation. I think there's also discussions on how do you place JAK inhibitors, for example, in case of inflammation, bearing in mind that we have the oral surveillance study with tofacitinib. So thank you very much. I think this was a very nice presentation, a very intriguing case, I must admit. Everything was happening at once, so I fully agree you need to act very fast to get the patient in the best outcome possible. I don't know if there's any questions from the audience or from our panel.
Maybe I'd just like to say,
just in the interest of time, maybe we can just do the second case and then.
Okay, so we'll go for the second case. Sorry, we can maybe discuss at the end some other aspects. Thank you very much, Dr. Salam. So I'd now like to introduce Professor Zahir Kutubi from the Cleveland Clinic in Abu Dhabi, and we will present the second case.
Thank you so much again, Dr. Shahara and Dr. Sabino, for having me. This is a very interesting case where I think we're going to talk about something which is not medication or anything. So I'm going to start with this patient, 32 years old female, diagnosed with Crohn's disease in 2017. It's an A2L2B1, seen by us at Cleveland in 2023 for the first time. Now, she had a past medical history of vitamin D deficiency and noticed to have a positive quantiferon test. Negative past surgical. She does smoke occasionally. Family history, father has diabetes, hypertension. There's no IBD in the family. And she was only actually taking Imuran, 150 milligrams since 2017. No other medication other than the Imuran. Now, the physical exam is negative. When she presented to us, she just presented to take over the care. So we decided to do the blood work as usual and then further investigation like the stool studies. And as you can see, the stool study was normal, 36, and her CRP was 2.3, which is normal. She was not anemic. Her platelet count were fine. And these are the things usually we concentrate on to see whether there's any activity of the disease. So again, normal CRP, normal fecal calpro, not anemic, and she had normal platelet count. So we proceeded to do a colonoscopy, and as you can see on the left, actually the terminal ileum was normal. You can see clearly the appendix, the right colon, even the left colon, and you can see the rectum. It was a beautiful, actually, colonoscopy with SES-CD score of 0. So at that time, she was in remission on, again, no medication except on the Imuran. Now, in July 24, she presented to the emergency room with abdominal pain associated with diarrhea. She was admitted to the hospital, started on IV fluid, IV steroids, and empirically on antibiotics. Now, I want to mention that the stool studies, and we do actually the GI pathogen, which actually give you more than like 200 bugs, and all of them were negative. And we did a colonoscopy, which showed actually mild to moderate disease. At that time, her fecal calpro stopped actually, as we will see later on, went up. Her CRP went up to 196, and even her platelet count went up, and she became a little bit more anemic. So again, high CRP, high fecal calpro, anemic, and high platelet, all of that will point to the activity of the disease. We did a CT abdomen, and interesting, showed actually involvement of the terminal ileum, right and transverse colon, and to the lesser extent, the splenic flexure and proximal descending colon, apparently sparing the rectum and the sigmoid and distal descending. There was also mural hyper enhancement. All of that was suggestive of enterocolitis from either the Crohn or possible infection or secondary involvement of the appendix. There was no free air and no abscesses. When you look at the CT scan, you can actually appreciate the inflammation and the mural thickening of the colon. This is her colonoscopy, and again, you can tell the difference. You can see terminal ileum was okay to, a little bit of inflammation, but you could tell actually the inflammation in the colon with the SES-CD score of 6. Now, when you look at the surgical pathology, you can appreciate actually there is a moderate chronic active colitis with the cryptitis and ulcerations, and the CMV was negative. Also, in the other part of the colon, in the transverse, actually showed again a chronic active colitis, and the CMV was negative. Now, this is what I mentioned initially, that her fecal calpro was very elevated, 7,350. Now, later on, actually, she progressed even fast to become more worse, and actually you could appreciate the CRP, which went up to 240, 260, and even up to 400, which is at that time I frankly don't like these numbers, and that suggests to me that there's possible either perforation or something going on. Her platelet count continue actually to go to be elevated, and she is becoming more anemic.
And
So,
if I may ask, at this moment, what was your approach to treatment? Because you have a patient which is indeed progressing quite fast from a CRP of 200 at presentation, or 196, I think it was, to 400, which is really, as fully agree with you, I would be very uncomfortable with these values. Did you start already at this moment an IBD treatment or just antibiotics due to the probably translocation?
Yeah, so basically she was on steroids and she was on antibiotics empirically. Now, the question for us whether to start her on any like anti-TNF or any other medications, but there's a lot of things taken in consideration. She's a not national patient, and if we give her now like infliximab or something else, when she leaves the hospital, she will not be able to have it. So this is major issue, for us actually when we admit patients who are not national. Though I could give her very easily without even looking at the insurance, but we look at it after she's discharged. How are we going to deal with it?
Yeah. Okay.
So let me continue. So this is her colonoscopy in August when she had the CRP of 400. And this is remarkably changes. You can see the normal terminal ileum, but look at the cecum. This is the appendix. And look, this is like the colon was completely shot. And all these holes in the colon. That's why my mind was, is she perforated? This lady had a micro perforation or something. And you could see on the right side, the large ulcerations, which actually were in the colon. So this is significant, actually, changes from the previous, even from the second colonoscopy. And you can see the difference. This is a huge, actually, what a bad disease. So this is the surgical pathology, now it's written as a focal acute colitis with ulcerations. Again, focal colitis with ulcerations throughout the colon. Now, what happened is actually patient was kept on steroids, and then for a few days clinically she did well, and she was asked to be discharged. She was discharged and followed up in the outpatient clinic. We tapered down her steroids. We stopped the antibiotics. Clinically, she was doing fine. And in March 2025, actually, this is her labs, the fecal calpo 160, her CRP back to normal, and the platelet 375, which is normal. Patient was still on Imuran, in remission, no abdominal pain. And we go again and ask the question, how did that happen? Was that only the effect of the steroid, which actually make her feel better? And I repeated her colonoscopy in March 25. That was approximately, I would say, 6 months after the event. And you could tell this is closely to be a normal colon. Look at the second picture. You can see the appendix. You can see the cecum, which is normal. And throughout the colon, things actually went very well. And this is the difference. You can see in 2023, initially when she came, she had normal colon. In August 24, the severe colitis, and back to normal in March. And again, you would expect these changes in patients who received biologics, but again, this patient did not. She received only steroids. Now, the question is what triggered the inflammation? Now, no infection, CMV was negative. She was only on Imuran, did not stop the medication. Patient was not accepting the idea of stopping biologics because of financial issues. Now, the question, she was actually, her wedding supposed to be on July 15, and I was invited, but on July 13, 2 days before, she canceled the wedding because of problems with in the family. So my questions, did the stress played a major role in her in the course of the disease? And we know that stress and inflammatory bowel disease, actually, it is a known link, and the psychosocial effect in the stress affect all the body and throughout the the organs in the system. So I'm going to go through a few slides which can address the effect of the stress and the impact of the stress on the inflammatory bowel disease. This is the European Medical Journal and the significance of stress in triggering IBD, and has shed light on the role of enteric
Sorry,
nervous system. Go
Doctor,
ahead.
there was a question. Did you anticoagulate the patients? There was a question in the chat.
Yes, as an inpatient, patient does receive actually anticoagulation, yes.
And do you know which antibiotic did you give her and for how long, just to have an idea?
Yes,
of course.
she received actually as an inpatient Cipro and Flagyl, which is the usual combination they give when they get admitted.
And you kept it for the full period of...
She received it for 14 days only.
For 15 days only, and afterwards just steroids. And
yes.
Okay.
In a tapered dose.
And okay.
Yeah, and usually how we taper 10 every 10. So I usually do 10 milligram every 10 days in these severe cases. Okay. So this research actually has shed the light on the role of the enteric nervous system in generating monocyte and TNF-mediated inflammation in the gut enteric glia through the growth factors currently stimulating the factor 1. So that link actually chronic psychological stress to IBD through two pathways, the hormonal and the neurological. So the hormonal one, actually, this is the cascade, ultimately trigger the adrenal cortex to release corticosteroids and reach the gut and induce inflammatory response by acting upon the enteric glia cells. And these actually monocytes then signal the TNF, causing intestinal cell damage, inflammation, and pain associated with IBD. The neurological pathway, stress-induced glucosteroids stimulate the release of transforming growth factor B2 from the enteric nervous system, and this also can lead to gut dysmotility, impairing the movement and food throughout the gut. So the conclusion from the study that stress play a significant role in the inflammatory response and impaired gut motility associated with this condition. This is a very extensive, actually, review on the the role of psychological stress in inflammatory bowel disease. It's a very extensive, actually, published in September 2022, which say that the psychological stress appeared to precede actually the IBD exacerbation. And possibly that's what happened to our patient. She had a lot of problems with the marriage and through the family. So further research actually need to examine the differential effect of stress on disease subtype and IBD flare-up and remission. So the stress is thought to activate the hypothalamic pituitary adrenal axis, which has been implicated in gastrointestinal inflammation. Neuroendocrine immune system alterations make disease exacerbation even more likely. So relationship between stress and disease activity with significant association reported in 17 studies out of the 19. And the stress preceded disease actually exacerbation in 11 studies, with 2 of these studies reporting bidirectional relation. So this is very interesting. 19 studies examined the relationship between the stress and the disease activity. 17 actually showed significant association. So stress was associated with subsequent...
Sorry to intervene, but do you know how many of these studies looked specifically at endoscopic of biochemical disease markers, or was this the link to disease activity specifically on clinical symptoms? Because I know that the old studies specifically looked at PROs. Was that also in those studies a link between the stress and, for example, endoscopic disease activity? Because indeed you nicely show a very severe disease in these patients.
Yeah, I have not seen in the study, I didn't read through that there were actually endoscopic changes, but I'm sure they had, this is a big study. I'm sure they had touch upon that issue.
Okay.
So they said the stress was associated with subsequent disease exacerbation in 9 studies. 4 studies found life event, again, preceded the IBD exacerbation. So whether, preceded or during the disease, during actually the actual stress time, that actually impact the disease. This is another study, the interaction between stress and inflammatory bowel disease in pediatric and adult patients. Again, this is one of the biggest studies, actually. This is Romanian. And they write that the gut-brain axis play a major role in IBD pathophysiology. The various type of stressors alter the gut mucosal integrity through different pathway, increasing the gut mucosal permeability and promoting bacterial translocation. So the stress is a significant trigger for induced acute flare-up of the disease. And the imbalance of intestinal microbiota, also with the activation of the macrophages, increase the synthesis of pro-inflammatory cytokine, induce anti-TNF. So stress is believed to activate the hypothalamic pituitary, as we mentioned, which has been implicated in the inflammation of the gut, of the GI system. Such alterations in the neuroendocrine immune system can contribute to the likelihood of disease exacerbation. Again, the stress increased the risk of disease flare-up through all the studies, and psychological stress and psychosocial impairment condition can exacerbate the intestinal inflammatory response, and the exposure to high level of stress can increase the relapse rate in patients with quiescent form of IBD. So in conclusion, the psychological interventions can improve the treatment effect of gastrointestinal disease, thus improving patients' quality of life. And if we go back and see what happened to this patient, actually 6 months, she is over that period of stress and her colon came back to normal. Now, whether you're going to argue that this is related to the steroid or related to the improvement in her stress condition, I think stress play a major role in the activation in the disease, and even can precede the disease activation. So we always talk about medication, and I thought this case just to bring your attention that always think about stress and the likelihood the patient's going through, and that can be a major cofactor in the exacerbation, not only infection.
Yeah, I think it was a really interesting case showing in another aspect of the disease, which is a psychological aspect and the impact on disease activity. I think personally in this case, I think the steroids also did a lot of the work for the induction of remission in this patient. But indeed, now looking at, did this case change your practice, and are you introducing psychological approaches to treat your patients on your centers?
Yeah, we involve actually psychiatry and psychology in our patients. It's very, very important. Now, will not change my treatment that patients should be on biologics as a main, treatment of the disease. But in some patients actually who cannot afford the medication, we're actually having some problem with them. But again, this patient, I'm sure she had no way to get biologics, even with the help of other institutions and help with the different companies. It was very difficult for her.
Yeah, I think it's
If I may, Zahir, this is really a phenomenal case. We're not
the pictures is
I'm not
unbelievable.
arguing. I don't think it's surprising that stress can trigger flares. I think it makes sense. But for somebody to come with such a flare, this is the kind of colon that is acute severe ulcerative colitis. Maybe if you want to think about two other diseases that can give you this, would be Behçet's disease, which is, superbly uncontrolled. And the third would be basically parasitic infection with Entamoeba histolytica, but that's easy to diagnose. The biopsy shows it very evidently in those cases. So I understand stress caused this in this patient, but how on earth did she get better? Because this is not the type of colon that gets better on steroids. We all have this kind of experience. And had this patient had insurance and received anti-TNF, you would have thought, see, I saved you because I gave you anti-TNF. It's phenomenal that she got better.
I wanted to bet that this is an infection, but
Yeah, but
we do the GI
infection gives
pathogen,
you
it was
this.
negative.
No. Like you said, the multiplex PCR, although I don't like to use it, but it was negative. But then the biopsy, usually, when you're looking at invasive pathogens, the biopsy shows it. I mean, E. coli, salmonella don't cause these kind of invasive deep ulcers of any kind. You get this colitis that is obviously can be severe, but not to this extent, and certainly not going to get better on steroids anyways.
Professor
And,
Ali,
and
can
6
I
months,
add
only
something?
6 months get better. Within 6 months, the colon is back to normal.
Yeah, I think we saw a similar case, not with the stress of the marriage, but with Entamueva with the same with same image. And I must admit that the pathologist, the diagnosis was post factum. So at the active diagnosis, we took biopsies and there was no Entamueva seen. Only afterwards, when actually the patient developed a liver cyst, a liver abscess on anti-TNF that we started for Crohn's, is that we went back and diagnosed on the first biopsies the Entamueva. But that's why I was asking for the antibiotics, but I don't think the Entamueva would just
I mean, it's covered with the metronidazole.
It's indeed.
Can I add something? First, the pictures of the ulcers in the colon is a little bit deeper than the usual for Crohn's disease. And these deep ulcers should raise the possibility of the TB because already you have a quantiferon positive. And I was astonished that you didn't do an gene expert for the biopsies because it won't show in the usual biopsy specimen sent to the pathologist. You need to have a gene expert to take it, or the PCR. So the TB could be in your differential, and luckily enough, she improved on corticosteroids, and this may
not likely.
may be beneficial for her. The second thing is that it is deep punctured ulcer, could be that for amoeba. And for amoeba, it would improve on the flagell. You already have Cipro and flagell. And on the flagell could be for 2 weeks, could be sufficient for her that help to heal that amoeba, and everything went okay after with the activity. And because the activity itself, I don't think the stress could make that such deep
although
ulcerations.
I think, correct me if I'm wrong, Zahir, I looked at the dates specifically because it was like July and August, and between the CRP of 200 and 400 was 10 days or 2 weeks. So she did receive the metronidazole during this period. So their CRP is not going to go from 200 to 400. Had this been amoeba, anyway, I mean, amoeba is a possibility because it gives these kind of ulcers. But from my experience, we don't have it often in Lebanon. I've had one case, but the biopsy is phenomenally classic usually.
Yeah, it's strange for me to be Entamueva because it was getting worse on antibiotics and steroids, and that would be fully cleared. I think the issue of the CRP. So, and the steroids were given for weeks or quite some time, right?
Yeah.
So doesn't matter what triggered this flare, because this seems to me really a Crohn's flare. If we don't identify anything else, if it was a virus that triggered the flare that couldn't be seen on the multiplex PCR, we are using it, by the way, very often nowadays. Still, I think it's probably due to several circumstances that the flare resolved. But the steroids, I must admit, I do think that they played the role here. It's not, I fully agree that it's not something that I would treat with steroids classically. But if we look at the data, it doesn't work all the time. There are some small group of patients that would really answer, because from all the data, from all the studies using now placebo-controlled studies where they look at specifically endoscopy, if that comes from an SES-CD of 22, that will never recover to an SES-CD of 3 on its own. So it needs to be something else, because the stringent that we are with the endpoints, the less placebo effect we see. So I think this case must be probably the steroids, some less stress, but I think the steroids certainly play the role in decreasing the inflammation at least.
I mean,
Dr.
clearly,
Sama, the patient was actually quantiferon positive. So TB, I mean, she can put all the differentials, even a missed infection because the labs didn't pick it up.
Yeah.
But anyway, steroids and antibiotics did the job for her. So
Dr.
anything
Kotibi,
can-
can I ask from where is this patient comes from? Because to me, I think this is a classic picture of amoebic ulcers. And I could put it as the first diagnosis of amoebic ulcers, amoebic colitis. And I think that the patient has received metronidazole and Cipro. Both could be acting against amoebiasis. So can you just tell me from where is this the patient coming
The
from?
patient is from Egypt.
Yes. So we have amoebiasis, and this patient could have amoeba.
But
This
she
is a
never left.
classic.
She never left the UAE, by the way.
Really?
Yeah,
Maybe infected by one of her relatives anyway.
that's also really an important consideration is I think exposure, travel history is important in those patients. Nevertheless, I think, correct me if I'm wrong, that I think the multiplex PCR does include Entamoeba histolytica in it. And I mean, to not have it on biopsy, not to have it on the multiplex, and to have a rising CRP on steroids and antibiotics, this case is really extraordinary, I have to say.
Something
Like
else.
like
Very
Osama's
nice.
case. So I think both cases today show that even with the best knowledge and experience and clinical wisdom, some patients defy everything that we learn.
Yeah.
Definitely.
But very nice cases. Thank you so much.
Yeah.
Really
But
appreciate it.
maybe to finish, because I think what they said at the end, it's interesting, not to treat acute flares, but we are introducing, and we did a study with mindfulness, for example, and we are doing studies with CBT. I was wondering in the Middle East, are you introducing also this kind of therapies, psychologists, mindfulness, CBT, to treat your patients in remission so that you can increase the quality of life?
Yes.
We do involve them very actively.
We have a patient association in Lebanon, and they actually do sessions with patients. So, I mean, it's not, I can't say it's universal and it's not practiced widely. It's maybe opportunistic and maybe just a few patients here and there. It's not easy to set up, of course, and who pays for it, etc. So those things come into play also.
So
just to mention
certainly
that,
not easy with us also. Yeah, sorry.
Just to mention, this patient was actually an ideal candidate from the beginning after the scope for IV infliximab.
Infliximab, yeah, of course.
Yeah.
Of course. I mean, I think if you show this patient to 100 experts, 100 will tell you infliximab. At this point. So fascinating. Anyway.
Yes.
Joao, may I close?
Yes, certainly. I would like first to thank you for the invitation, to thank all the experts that are here, to thank the two presenters, and also to thank the audience at home to be following this very interesting initiative. I followed the previous ones, and I think you're doing an amazing work setting up these grand rounds. Congratulations.
Thank you so much, Joao. And thanks to Mark and Bram and Severin and the whole team really for really partnering with us on this. We find this has really great value, even better value than giving lectures, because you learn so many things about management, about experience, wisdom, practice, etc. So thank you. I'd like to thank you again for moderating the session. I'd like to thank Zahid and Osama for really fantastic cases. I'd like to thank also our sponsors for this grand round, Takeda. They've been really highly supportive. And I want to invite you to our next session, which will be on October 15. For our third grand round, we'll be sending, of course, the information and the invitations to everyone. And until then, I wish you all a very happy and summer.
Okay.
Thank you.
Bye.
Bye-bye.
Thank you.
Bye.
Hello, and welcome to the IB Digest podcast from Takeda. I'm Will Mountford, and this is our second part of an interview with Dr. Ahmed Sultan about the use of histologic remission for ulcerative colitis.
If a patient were to come to you or to one of your colleagues and say, I've done some reading, I've heard about histologic remission, I want that. I think that's what is going to, in my mind, in my body, feel like I am cured, I am safe, my life is better if I get histologic remission. How do I get there? What would your response be to them?
First of all, the key to success of treatment is an early diagnosis. So if you have the symptoms early, you need to be properly investigated and don't neglect your symptoms. Second, once you have an early diagnosis, you need to initiate the proper early treatment as well. The proper early treatment should actually, once you have an early diagnosis, you need to start the proper treatment for your case. And this is by assessing your disease severity. Like we said before, if you are young in age, have extensive disease, your CRP is high, you require systemic steroid at the start of the treatment, you are likely to need a higher and a more advanced medication than the conventional therapy. And here comes the role of the biological agents or even the newer small molecules or the JAK inhibitors. Once you have an early diagnosis and you initiate the proper therapy, the third part is to have a good adherence to your medications. You need not to skip any dosage. You need to do the proper follow-up with your physicians. You need to repeat your lab test on a regular basis, assess your symptoms clinically on a regular basis, and you also need to repeat the colonoscopy on the proper time as advised by your physicians according to your case. And ulcer supplies you usually repeat within 6 months to assess the medication's efficiency.